So I'd like to hand over to Karina Shea for the panel. So Karina is is a trained clinical pharmacist. She's a doctor of health economy from the University of Groningen, in pharmaceutical industry and clinical pharmacy. She's now a consultant health economist in Switzerland, and she really focuses on assessing value add of orphan drugs. And so her passion or motivation is to improve patient access to treatment, improve well-being, and generally also think about sustainability of healthcare system or service provision. Has been speaking at the European Parliament on the Patients' Rights Day, several professional facilitator. So thank you so much for joining us today.
Nora.
Oh, yes.
Thank you very much, Laura. It's wonderful to be here. Why? Because I'm absolutely passionate about improving access to treatment for patients with rare and ultra-rare diseases. And you may ask, well, how come? I don't have a rare disease and I don't have children with a rare disease. But I come from a clinical background where I witnessed children in particular, Great Ormond Street Hospital in London, where parents were doing, like many parents here, knocking on doors, asking doctors for support, asking for a diagnosis so that they could understand what their children had, and then seeing some very difficult journeys for parents and children. And that made me think, I need to do something different. I need to have the knowledge, the tools, and the expertise to help people anywhere in the world with rare diseases. And I moved out of clinical practice and went and did a master's in health economics so that I would understand how to have an argument with the health authorities, the regulators, anybody who pays for treatment. Depending on the country, it might be the government, or it might be private health insurance. And from that, I developed or went on to do the PhD research in something very niche. How do we assess the value add of an orphan drug? Now, let me explain how it's done for aspirin. We all know what aspirin is. A new painkiller comes on the market, a company submits their dossier, and the organization that are reviewing it will say, is it cost effective? And the way they measure cost effectiveness is to compare the new treatment with whatever treatment exists. But how can you do that for a rare disease when there is no treatment? Automatically, by definition, if you compare something new, even if it's only $100 per tablet, it still isn't going to be cost effective in the terms of cost effectiveness as they are used when you compare it to nothing. And that's why I spent many years researching it. And that's, in a way, how I come to be connected to Nora. Because my passion, as I said, is about improving access to treatment. But in order to do that, we have to understand the diseases. We have to understand how to present the diseases to the authorities. And by authorities, I mean as an umbrella term. It can be health authorities, it can be government, it can be lobbying and patient advocacy. But let's just call it raising awareness. And today I'm delighted to kick off with some parents who are going to be asked some questions. The reason being that the more we talk, the more we share, the more we will learn about this disease, which is quite a broad spectrum, even though at the moment we believe it's an ultra-rare disease, meaning that there are very few patients worldwide. We still have to learn from each other. And I'll come to why that's important a bit later. Now, some of these questions might make people feel a bit vulnerable. If they don't want to answer, and this applies to people in the audience and people online, they can just say, I'd rather not answer that. But I want everybody to remember that by sharing, it shows that we care, and we then empower ourselves collectively to move forward. So even if it makes you feel vulnerable and emotional, remember that it is for the greater good of all our patients. Please help me welcome one of our first panelists. I'd like to invite Stephanie up. Stephanie. Stephanie is from the Netherlands. She's mum to Milan, who's 5 years old and has AG01. Two, but I believe a milder version. Yes, I have no clue what mild means on the spectrum at the moment, but perhaps by the end of this morning session, we'll have a better picture. Thank you very much for joining us. Our next panelist, Antje from Germany. Mum to Finn, and I think many of you have already seen Finn energetically running around, being very friendly and affectionate to us all. And he's 7 years old, and he's AG01. Two, also two. One of you with one. Okay, he's AG02. And our third panelist is Ashley, who's coming from the US to be here with us. Please welcome her. And Ashley is mum to Riley, who is 15, and is an AGO1. AGO1. And with that, I would also like to say that Ashley's parents joined us from the US as well. So and a huge word of thanks to panelists and to all of you online and in person. Now, just a quick message to everybody regarding questions. If you're in the room and you want to ask a question, raise your hand and I will come to you. If you're online and you want to ask a question, please type it in chat. Now, don't worry if your question doesn't get asked immediately. Manu is controlling the questions in a themed way. So she has the list of the themes as I'm going through them, and she will prompt you when she has a question from somebody who's online in relation to that theme. As I said, if you don't want to answer a question, just say, I'd rather not. But remember, sharing is caring and empowering. So, ladies, and you don't want to go out of sync. Firstly, I'd like to turn to Stephanie, because if I remember correctly, Milan's mild, but at what age was the diagnosis? And before the diagnosis, had you noticed something to concern you?
Milan has an older brother, so we compare to his older brother. So we saw not extreme, but this milestone for later as his brother. He started talking very late, and he went to a special school to this. It's a special school with much speech therapy, and then this, he could speak and talk very quickly. He improves very well, so we didn't know what was wrong, but there was something wrong because he didn't start by himself. He needed the therapy to come to it. We were wondering maybe something, he has some autistic symptoms. His muscles were a little bit weak, so there were problems and different.
Yeah, a difference in milestone reaching.
Yeah. So they were wondering maybe it might be a syndrome or something, because there were more difficulties on
Different spectrums, different levels. Yes.
and we started the genetic investigation when he was 2 years old.
Right.
And we got the diagnosis half a year ago.
Right.
So that was very, very fast, and so for us, it was quite find what was wrong. We knew there was something wrong. We knew it was different, but we didn't know what was wrong. Yeah, after the diagnosis, we just had a lot of questions. What to expect? It's such a new syndrome, so we still have no answers.
Yeah. Thank you very much, Stephanie. And moving to Angie, who's got 7-year-old Finn, and I think that for you it was different because you knew at birth that something wasn't quite right. So if you could just walk us through that.
Quickly. Okay. Yeah, so Finn, maybe some of you saw Finn, happy boy, chasing around, loving basically the world and everyone. And when he was born in 15, March 15, it was quite clear from the beginning on. So he was born, he was okay in terms of all APGAR norms, but then he stopped breathing and he got immediately to the, well, after 1 hour, we got to intensive care where they reanimated him, and they basically, I think they just took an arm and they said, okay, this is something really, really weak. This is something that's not, should not be left. And so from the beginning on, we found our son back at the intensive care, like doctors around saying, okay, this is not normal. This is, he was okay, he was breathing then after a while, but we stayed in the hospital to monitor breathing and so on. And this is also, luckily we stayed such a long time because we did the first examination, investigation still at the hospital. And to be honest, it was, I think for every family, it's a decision where to get your baby. And I'm not the person taking a risk on this, and I'm an adventurous person, but not when it comes to birth. So I choose the hospital with intensive care, the best we have around, and that was the best choice ever, I would say, because we had everyone around, taking him to the MRT, really seeing from the beginning on, okay, this is something that's not okay. And we had, I think after 2 days or 3 days, we had the MRT telling us, okay, the brain is also not okay. So there's something interrupted between left and right. So we do not have a connection. And I remember that is always the fun, but it's a nice story at the end when they say this is something that gives us an indication of something more, bigger problem behind. And they send us to psychologists. And if you know the psychologists at university hospitals, they are quite young. And I had the feeling, wow, this is like half of the age of myself. And she's telling me, you have to deal with a disabled child. And I was like, no, why? No one told us it's disabled. And this is where it all starts, I would say. Like getting this plant, the seed planted. Okay, this is a longer story that starts here, and it took us a long while. So after 6 weeks, we left the hospital in the unknown, of we don't know. Now there's something wrong, but we don't know. I spent the first year with these oxygen meter, was sounding all the time, and they waking us up all the time. So his boy is not breathing anymore, and it was very, I would say, very intense. And then it took us, I think, a year and a half or so until we got the exome analysis. And I must say it changed something, because living in the unknown and always with the risk of his boy surviving or not, and at the beginning, I think every mother knows it's like, also with healthy children. Yes. Is it breathing? Yes. And we had that very attentive, is that boy breathing? And with the analysis and with the fact of AGO1, it went much. What's sort of a relief, he said. Okay, he's got a name for it. I could go on.
Thank you very much. The exome testing is, as you know, the genetic testing. Now, for Riley, it was a little bit different, I think, and she's going to walk us through that, because if I'm not mistaken, things were okay until the 18-month-old fever. Was that? Over to you.
So Riley, we had a developmental milestone. We were seeing pediatrics, I was doing kind of more than according to plan. And then in about 15 months, I started getting a severe ear infection. And we were kind of just waiting for them to have an opening at that point to have like 6 minutes years. And while we were waiting, just a couple weeks away from that, Ryan developed a fever. So it was actually Christmas. I saw him on Christmas, and he was, you know, talking and laughing. He had rosy cheeks from his ear infection. And he was on antibiotics. He had never had a fever before this point with any of his infection. And then the next time I saw him, he stopped making eye contact. Stopped speaking, really, lost all words. Just behavior change. She was very into like sports and kind of rock play or basketball and baseball, things like that. And all of that stopped. We purposely take the ball and throw it away. You know, so very direct and deliberate of what he wanted. There's just a complete change in personality as well. And so that was with the 18 months. And in the United States, it took a long while to get an evaluation, referrals, things like that. So he had just turned 4, and it was in 2011 when he had initial workup at Mayo Clinic in Rochester, Minnesota. And the original genetic testing was very minimal, I believe, and that everything was okay. The whole entire workup was totally normal. And our pediatric neurologist had just said, no, I can't put my finger on it. I've never seen anything like this. Everything was normal, so to speak, but it clearly was not normal. And as time went on, I think it's related to the difficulty of communication. But as time went on, now he's my height, my weight, 15. If he's upset, doesn't want to do something, it's, you know, becoming a bigger challenge.
Yes.
So I want to say in like 2016, we had the whole exome genetic testing, and then it took about a year for results. And at that point is when we found out that I was 1. And at the time, I was told that he was the Rochester's the first in the United States that we had known about, and there was 4 or 5 other families in Europe. We was in a study with them, and then a couple of years passed. And I got a call from Rochester, and they said, you know, there's 20. He's one of 20 in the world. This is what I've been told. And now that's enough to be a syndrome. So it's incredible how, I guess I didn't anticipate us being here in that whole time where we were so in the world. So yeah.
Thank you very much. Now, once you have a diagnosis, what next? Is there a treatment? We've heard 3 different, very different scenarios. But the next step is not even dealing with the treatment, because we don't really have one other than all the different therapies, speech therapy, physiotherapy, occupational therapy. But what about dealing with the family and the extended circle of friends? And because Stephanie has an older child, I'm quite interested to find out, and I think our audiences would be too. Have you had to explain this to your older child, and how do you explain it? And how does your older child, it's a son as well, how did he respond?
We told our oldest son 1 month ago what was wrong with his little brother, because he turned 7 half year ago. So and some other friends of him asked already questions to their parents. If something was wrong with the little brother of our oldest son. So you know, he felt we should be very telling him what was wrong, because he would pretend his friends would ask him the question. Yeah, we just it's quite difficult to explain what's really wrong in the technical part. But we just explained that Milan is the name of our son. The genetics is we explained it's a big puzzle, but one part of the puzzle is missing. Yes. And because one part is missing, it doesn't work the way it should be. So Milan is in some things it's a bit different with this part. So he understands it, and sometimes when Milan is having difficulties with things, what's shouldn't be difficult at this age, then we explain it's because of the little
Piece of puzzle.
yeah, piece of puzzle that's missing, but it's more. So, and I think our older son, the way he acts with his brother, I think he always has known there is something, and he needs some extra. He's very caring about his brother. He has come, I will help you.
Lovely.
Yeah, yeah. So I think without knowing what was wrong, I think we already knew there was instinctively. Yes.
Thank you, Stephanie. I think very important to be able to share it with siblings, older siblings or even younger siblings at the appropriate time. And it's knowing as a parent when your child can take that on, a younger or older sibling. And then I think there's the extended family, grandparents and aunts and uncles, and beyond that, the social circle. How does one tell one's friends, and what are the repercussions? And for this, I'd like to turn to Antje, because she and I had a chat during the week, and I think that she can give us a lot of insights about friends and how they cope, or rather how you cope.
Thanks, Ina. Yeah, I think that's a big topic. I call it the team fit topic. And it took us a while until noticing that the team fin or team Milan or team whoever is required to do with this. I'm also today taking the position of saying I'm really giving up responsibility as well to others. I can't do that alone. I think that's the two learnings I would like to put on the table. In terms of team fin, there's obviously cycles around us. It's my parents and very, very close to us, helping us a lot. But then, to be honest, it always stops to a very major extent. Because yes, we have friends, a lot of friends of mine having kids of the same age. We were all going through the same story of having babies and so on. At the same time, they grew up more or less together. But still, there are very, very few people around us that really understand how to deal with it. And this is, I think, for two reasons. Also trying to understand and not to stop blaming. Because I mean, people in our age are in the rush hour. Everyone's working, building their careers, having kids at the same time, where to live, building houses and so on. I think it's very difficult to understand and putting themselves into the shoes and dealing with the problems of others. And this is something I really notice in my inner circle. I wouldn't doubt friendship, but I doubt that they really have the power and the energy to deal with our problem. So I think this is something I learned definitely to let go and say they are friends, but it's not their responsibility to take care of us. It's us.
Thank you. And I think that that's something crucial for parents to remember that your friends are there in friendship, but they're not there necessarily to be co-carers. And for them, their naughty 2-year-old problems are just as big as your problems with your child, because it's all about perspective. They had a sleepless night, you had a sleepless night, and that's all they can relate to. They can't relate, if they haven't experienced it, they can't relate to what parents with children with any disease, rare or otherwise, are going through. Now, I'm going to come over to Ashley with a question regarding, as a mum, did you decide to stop working? Did you give up your career? Where does that leave you in terms of social and career?
Actually, I advanced my career. I got my degree as a nurse practitioner because you have to financially support your family. I work in family medicine, so I have set hours, which I thought I would really support but I think that it's important what you need to do for your family. And I think the right decision
Yes. Thank you. Thank you. And you've touched on something, and each parent has in a different way, which I talk about the guilt that parents feel. And I strongly say, don't have any feelings of guilt. And Angela's really put it together very well when she says it's team. And you do need the team. And you can't do it on your own, and you shouldn't do it on your own. And that brings me to our next topic, which is looking for support. And when I say looking for support, I mean the physical support, the extra pair of hands, physical therapy, occupational therapy, speech therapy, any of the therapies that you need. And I'll actually, all three of our panelists will answer this question about how they go about looking for support. And the final part of that is, if they've needed financial support, how they've done that. So each of them in turn will tell us what support they've needed and how they've reached out.
He was at the special school intensive speech therapy. He turned 4, and then he has to go to school. And the question was which school was best for him, and because they saw they considered he could start at a regular school with some extra help. But then we needed to start speech therapy, physical therapy, and there are, after we got the diagnosis, they were able to get some extra money to invest in an extra teacher in the class, not the whole day, but for a couple of hours, which is at this time it's enough to help me now to go to a regular school in the middle of normal kids without diseases. And at this time, this works. This works good.
Right.
And yeah, it's because of the school and the I think the syndrome and the extra therapy, he already got on special group before he went to get the kindergarten, yeah. How do I say?
So the school reached out, obviously
They
to
helped.
local government.
Yes, they helped us.
To get the financing so that they could get the help in class
The financing, that's by.
done by the Department of Education for the local. So,
Yes,
Right.
yes.
right,
So financially, doesn't have any
impact on you as a family, right? And you don't have to take him for additional therapy outside of school.
Yes, we do, but yeah, the physical therapy is at school during school times. And at first, the speech therapy was during school times too, but we discovered we have some extra. We needed another local therapist, someone who does speech therapy.
Right.
With some extra knowledge, and the speech therapist for the school, she had not
The extras, expertise.
Yes,
Right.
yeah, so one time, a week we go to another speech therapist, not during school times, yeah.
And is that funded through the local health services?
Yeah, the insurance.
Yeah, through the insurance.
Yeah.
Okay.
Yeah,
That's
and
okay.
physical therapy as well.
So Team Finn is having two major building areas of working areas, whatever. It's the first thing is the motoric and fighting the hypotonia, and that was in the middle and in the center of the first years. Building muscles, building tonus, getting him up on his feet. That was a big area in the first years. And now, as he is on the feet and is unstoppable, we switch our focus to speech. Because this is something, so at the beginning, I would say we were running with speech and physiotherapy at the same pace. Now we have him on his feet, we work a lot, he worked basically a lot on it. We found very good specialists in Cologne, in Germany, that put him on a very special treatment, and I think that was the major thing, because for his, for him, it's very difficult to build up the tone, build up muscles on his own. So we put him in a center for, it's a vibration plate. It's a little bit like power plate. And you put him on it, and externally the muscles are stimulating. I would say without that therapy, he wouldn't walk today. That was, and we have this thing at home, and we train every day. So that was really good. Now focus is shifting as we see speech is not developing. It's not even starting to develop. So now we say he gets his physiotherapy two times a week, not 2 times a week. Changed to speech. He always had speech therapy. That was part of our team. We had a very good specialist there. Now, as he went to school, our system got sort of disrupted because in school we got a new team that doesn't work. Today it doesn't work. It's not. It really makes me unhappy. Because we do not have the treatment that is. We have our plan and we say this needs to be in the plan. At the moment, it's not. So that makes me really upset. So that shows also having a good team, investing in stability of the team is very crucial. But it's also sometimes the team gets disrupted, and we find a new way to stabilize it.
And financially, how does that work?
I mean, Germany is wonderful. We all get it paid through the state.
And now, going from Germany to the US, I think it's a very different picture.
So, the ear infection fund, I did private speech therapy. And I admittedly healthcare would have considerably, the insurance that we had is good. However, there was a lot of anything from early speech therapy, private speech therapy, to the communication device, dialogues that my son has, to different schooling, anything like that we've always been denied, medically excessive or medically unnecessary, experimental. So we're talking probably a year minimum for each step of something that we tried to do. So that was.
So a delay of a year,
Yes,
it takes a year.
multiple appeals.
Yes.
And things like that. So Riley did have a little bit of private OT for sensory, a little fine-motor. He does have some hypertonia. It doesn't limit him at all. So we kind of shifted away from that as well. And that PT OT was private. And then in school, I've always pushed the speech more than the educational system wants or thinks is necessary as well, because I feel like that is underlying the issue of behaviors, the communication, barrier between us. He was in the public school system starting at age 3, 4, and mainstream was always their goal. It was not mine. Because our school, as much as they tried, they had no experience in a very small town, no experience of anything like this, behavior or communication to that extent. And so then he was kind of pulled into the resource room for a while. And then I think as a 3rd grader maybe, he was going to a school for autism that was 60 miles one way. It turned out, and that was through the public school resource, which was actually a really great place because most students there were nonverbal, and it was the first time that I actually felt that someone understood.
Yes.
And behavior just kept escalating. So when Riley was 10, he actually moved to a residential and educational facility about 2 hours away from us. Our state in Minnesota, they have moved away from like facilities. And they are person-centered care, which is a concern of me personally, because we talked about team thing. Multiple people are needed, so if it's, there's just one support staff or something like that, it's just not enough. So the school, I call it school, it has a home, which is ours.
Yes.
But they have the dorms, residential was attached to the educational facility, and PT, OT, speech, behavioral analyst, behavioral therapist, his psychiatrist will come there and do rounds, pediatrician does rounds there, dentist comes there. So everything is there, it's staffed. There is definitely in the field working with special needs where kids have difficult, challenging behaviors, staff turnover is huge, which creates disruption in the programming. Everybody tries to do something a little different. You have to know your child has to develop rapport with them so they can get in there. But overall, they is comfortable there.
Yes.
So it was an extremely difficult decision. But it's proven that that's exactly what it needs to be. So my biggest fear at 15 is now what's going to happen when you leave.
Yeah.
So thank you.
Yes.
I'm coming up. I was about to look at you and come back in the room.
You're now going to hear from Debbie, who has a 20-year-old son.
So listening to the United States issues, the one thing that I'm assuming other countries would be much easier, but what she's saying, of course, their best advocates are their parents. I'm lucky my husband is very involved, but I really take care of all of the doctor things. And from the day I brought him home from the hospital, I kept telling them something, was different. I have an older son. And the doctors try to make you think there's something wrong with you. And it's so important to know that you need to stand your ground and say, no, this is what I'm seeing. For the schools, I will say, the best thing, especially for, I'm assuming, kids in the United States. We also pushed for, him to be in what they call EC classroom. And they pushed to mainstream. Right. They pushed to mainstream. So I said, okay, we can mainstream, but he needs what they call a shadow. Someone to sit with him, because he has to be redirected. They wouldn't allow it. They kept denying. The IEP meeting, I would end up in tears because I'd say he had behavioral issues because he's being mainstream. So it was a non-stop battle. Finally, we were lucky, we got onto a program in North Carolina called CAPC, which, we were taking out loans to pay the bills, and social worker said, go to social services. They looked at our money and said, no, you don't qualify, but this CAPC program qualified him for Medicaid. And that really helped a lot, but the one thing I will say, they gave us home healthcare workers. And the first company we were with, it seems, at least where we live, they don't hire very educated people, and things were happening while we were gone that we heard about. So the next company, I started to do all the hiring. So I would put an ad in, and that's the one thing I will tell, that anyone can do that with their services in the United States. And then I basically did all the background check, and then once I found something that I liked, then I sent them to the company. But we have 40 hours a week of home health, and not one person can do that. I mean, even one person for us, So we have multiple people. So now I also do the scheduling because that was, the companies can handle. Yeah, team boss.
So you can hear that it takes a lot to organize. It's a team effort. In some countries, we're lucky enough that it's supported through the state or through the insurance. But we have a question here from online, so I'll pass the mic to Matt.
There were some interesting questions and comments section from the chat. First one from Jason, also from Minnesota, USA, who wrote, I was seconded in the US for our daughter Lauren. It took almost a year of denials from the medical systems, but we kept fighting. We paired up with companies to pay for tests and fought with insurance companies to get approvals to get our diagnosis. That's the first comment, and I have also a question to Ashley from Naomi, mother of a 12-year-old daughter with AGL1 mutation. Question is, Ashley, are your farm pressures controlled? What is the most important outcome of a possible treatment for you? Improvement of cognitive abilities or accuracy?
What's that mean? Oh, sorry.
My son actually did not have seizures. We are very fortunate suddenly. Sorry, what was the question?
What is your goal for treatment?
Oh my goodness, when he was little, my goal was just to have him talk. That was my goal. And then as the behaviors escalated, around 10, he moved to the facility residential area. The goal switched to behavior management. Now those behaviors are stabilizing. Now my goal again is to work on communication. My goal is always communication, but goals are independent living skills. It's very clear he will not live on his own, but I want him to have some kind of a purpose and a job or just something that he can do. He's very organized and things like that. So I guess the goal is really to maximize his potential. And again, stuff that's 1 year. We're told that if there's any growth at all, that's environment. So to just be thankful that there's still progress.
Thank you very much. sorry, parents, thank you, no, thank you very much. I think this highlights that for parents, the goal is constantly moving. And when you start off, you think of, let's just get them on their feet, and then you start thinking about communication. So it's so raw what needs to be done and how to do it. I don't know, do we have any other questions from the panelists? Okay, now I'm going to come on to a subject which might be difficult for some to answer, and they don't have to if they don't want to. And I would like to know from parents, both on the panel or parents in the audience, do you think about having another child once you have a child at age year 1 or age year 2, or for that matter, any other rare disease? How do you assess, or do you think about it, or do you choose not to? Now, as I said, this might not be a question that people want to answer. If you do want to answer, raise your hand. If you don't raise your hand. And if there's somebody online who would like to answer that, let me know. So the question is, you have a child with a rare or ultra rare disease, do you think about having a second or a third child? Nobody wants to discuss that. Yeah, okay, yeah.
We don't start a child and born pregnant from here. We already knew it should be the match baby. So there was another question, we would go for a third child or not. But after we go through all this and all the difficulties and it costs a lot of time and everything, now I'm very sure we don't want it. We don't want a third child.
We did not have any diagnoses after, and I thought it was related to the illness infection, honestly, that Riley had. So when I encountered 3 years later, he was neurotypical, but I agree, especially like at the 15, 18 month, I was just like every day, like, you know, what's gonna happen, whatever. Fortunately, is healthy and well. But one of the things I had always asked was that it's de novo. So once we found that out, and I'm wrong in thinking that that does not mean any other children I would have will have that. Yes. Yes, please, I'm passing to the member of the audience.
So, even there, we have to say that the gross majority of the cases, if the variant is the known variant, there is almost no chance that the second child would have such variant. But there are rare cases of so-called gonadal mosaicism, which means that the variant is present just in some of your cells, just in some of your beta cell ovaries and the sperms. And we cannot exclude this. For this reason, we offer always prenatal diagnostics to parents who want that, even in the cases where the mutation is needed.
So would I have to, or would you recommend my son Connor be tested before he had children? Because he has no symptoms.
I don't know. So you either have a unaffected child.
Yes.
And how old is Connor?
12.
Right. Okay. Thank you. We have another comment there from the audience.
Hello, my name is Timo, and our child is Alexander and has AO1. He's new, he's 9 years old. The question of the second child, at this situation, we have 2. Alexander has our older sister and brother. We have 3 children, maybe 1 or 4 child. But when we imagine that Alexander was the only child, we would have to say I won't second. Because Alexander's situation makes us as family, husband and wife stronger, but the time and the power we have to, what we have to investigate for Alexander's education and that he can do private himself, power himself, but to put so much power and time, and I think we don't have the same power and time for another time. This is my opinion.
Yeah, thank you very much. In fact, I'm coming back into the room, and this was a question that I really wanted to put to you, so you disappeared at the wrong time. Here we go.
Make a counter statement that reminded me very much of the discussion I had with my partner when he was 3, or no, he was 2 and something. We sat down at the table and we said, okay, what do we do? Do we have a second child? If yes, now, or never. And we had the discussion and we took that position we did and said, we got so much to do, it's too hard, we can't deal with it, we put on jobs, we can't have another child, just not, we will not manage. And I said, yes, we will manage, we will, and it's just too much. And then we took the agreement to say, we will try to have a second child, and we will do everything to make sure that does not happen again. I think that was a very clear decision from the beginning on that we were agreeing, we cannot repeat this story, but yes, for a healthy child. And I think that was what we chose. And we had Emmy, and we took, when I was pregnant, to examination, this really cool stuff. It wasn't fun. It wasn't really hard to do. To get the water.
Amniocentesis? Yeah, to get the amniotic fluid and to do the testing.
Yeah, and they did the testing of the unborn child on ADO2. So we didn't do it like complete, obviously, but we said we want to exclude this genetic defect on the time, and that was okay. So we said yes to Emmy, and Emmy, to be honest, changed everything. Everything. I was the mother of a disabled child before. With Emmy, I'm a happy mother. And I didn't go to playgrounds before. Today I go to playgrounds. And it really changed the perspective and everything. Best decision ever.
Oh, lovely. Thank you very much.
A question for Davo, probably. So I suppose many rare diseases are known by now, and these could be tested for. How many other rare diseases that are not known yet do you think are there, and are they just super unlikely? So it's a tail risk to have another child with another disease, or how would you assess that?
This is a very hard question that we asked. How many diseases there still are that we know? It's very hard to speculate. There for sure are many. But it would be really unserious for me to say them. So, and there is actually the actual question is, what are the chances that the second child would have a genetic disease?
One that's not known yet, and that couldn't be diagnosed before.
And again, this is not very easy. There are several diseases that most of the countries routinely tested. When the parents reach some age, usually 35 years. What we know is that most of these novel variants are correlated to the age of the father. So the older the father, higher the chances are there will be no variant. But we cannot test it. And even if we could test it, there are huge ethical problems in this. Because what we find a lot are variants which we cannot characterize in a way they're saying these will be really disease-causing variants. So we identify variants which we would address as variants of unknown significance. Based on this, we wouldn't be able to tell anything. Because variants that are identified, we always correlate them to the clinical. And in most of the cases, during the gestation at the time that we do this, there are no obvious anomalies in ultrasound. So it's almost impossible to correlate this variant of unknown significance to a possible therapy. So in other terms, it's very hard to say, but if we go from a statistical point of view, the chances are extremely low. You will have two kids, one after the other, who have no variant. But I can tell you about statistics. I can tell you this is chances are 0.001%. If you are that person, you don't care about it. This we cannot.
Thank you very much. Now, we've heard about another question. Oh, love it. This audience are so interactive. I love it. Thank you.
I just want to say something. Then my oldest son, he has Apple II. And this is my second daughter, she has Apple II also. And my third son, he's 14 years, he doesn't have it. And long time ago, they didn't have so much research. So I have a very difficult time because they want to believe that something was wrong. I got my daughter, she had different symptoms. So I thought, oh, everything is going good. And then she got sick. I don't know what they call it in English, False-Group. Yeah, she got that. And then everything started going different side. She started changing, like the lady said. And so then at that time, they didn't know what it was. They wanted to take my oldest son from me and put him in an institutional facility, facility for handicaps, because they thought I couldn't take care of him. And we had to fight very hard to keep him. And we, even with school, everything, so we didn't have much support. I had to do everything myself. And my husband was working, so it was very difficult. And I find this conference, I find this is good because now people can know what it is and can get help. And that's very important because you feel very alone when you don't know what it is. And so I just wanted to see that. And you were saying something on the second child again.
This was just what I was saying. In most of the cases,
Okay.
there is no variant. Chances are extremely, there are no chances that there will be a second child. But there is this exception, like your family, and there obviously is the corridor mortality, which means that if you some of the cells is carrying this variant, likely only included, then there is 50% of chance your other child. This is exactly, and we can almost never completely exclude this one positive. This is also the reason why we offer prenatal testing to Antje, she told us that she has a wish for second child.
Yes, thank you.
I just want to make sure I understand. We had a neurotypical older son who's 22, who sometimes doesn't have neurotypical, but we tried to get him tested genome because they did genome testing on us when they did our son in looking for mitochondrial.
Yes.
Right? And they didn't find his AOG2 at that point. It wasn't there yet. I mean, it was there, but they didn't know to look for it. But if my older son wanted to have children, should he be then tested?
But
That's what I didn't.
yeah, based on what you were saying earlier to Ashley, another child, a sibling wouldn't be tested.
No, okay.
Would not need to be tested. because it's de novo related to you. Right, so, yeah, we have a question from the chat.
No, not a question, just a comment. Parents at the chat just that both were too fearful to try again. So that's a big issue, I think. And I want to add something from my own perspective, as I am a mother of a 16-year-old girl with AGO2. And in my case, it were the doctors who said at first, why don't you get another child? Which was not motivating at all, because it was like, oh, you have to get away this first child in a way. And nevertheless, I got a second child 9 years after the first one. So and before there was a possibility of diagnosis, so there was just not knowing what happens, because I also knew parents who have 2 children with the same disease. So, but it was just a decision by heart, like in Antje's case, I think. And I can also say that it is, it's just something which adds something. It's not making something easier or different with the first child. I think it's just my special relationship to my first child, but it makes a wider range in my family life, I think, and what is really special is the relationship between the young and also older children, as you said, Stephanie, with my daughter with the disease, because it's something you can't compare with adults. It's just really, really healing also this relationship between the siblings.
Thank you very much, Mona. So we've heard about genetic testing and the day-to-day burden of disease. And one thing that I can imagine is that when you're dealing with children who have difficulties, you're constantly chasing after them. We saw Alex yesterday giving you a bit of a test for your money, running up 2 flights of stairs faster than either you or your wife could do. And one of the things that I would like to touch on very briefly is how a family copes with the negative energy of saying, no, don't do that, and re-explaining over and over again. And for this, I'm going to turn to Antje, because it was something that we discussed, negative energy and always saying no.
Yeah, so that's a very interesting question, because one, you are parents of the child. The parent is there to love the child. There's nothing you can do about it. It's a duty, it's something natural, it's something that's there. So you have to give love and you have to receive love. This is a natural relationship. But what happens if that relationship is disturbed by a constant, hey, don't do that, hey, don't do that, hey, don't do that, and don't do that, and don't touch it, and don't do that. This is adding a perspective to that relationship, which is very, very negative. If I want, and Alex, you may confirm, we can do the whole day, don't do that to our children. And this is something which is super, super difficult to deal with, because it is, society expects from you, you have to love your child. If you don't start complaining, hey, it is hard, it is difficult. Hey, this is really annoying. This is super, super difficult to deal with. It somehow doesn't fit into the picture. And this is something I'm thinking a lot about. I don't want to have a negative relationship with them. But still, sometimes we get on our nerves. This is something not easy to deal with.
Yes.
Still, I'm loving them. And what it makes or happens now is I don't allow myself too much to complain, because the society don't want to hear that. They will immediately turn back and say, hey, your mother,
It's your child, come on. That's something really difficult to do. Thank you very much. Anybody else got any comments on coping strategies, day-to-day coping strategies? No, yeah, Debbie.
Well,
Wait. There we go.
I will, in the very beginning, we used, behavioral strategies at home, with the reward system that I developed, and as we've gotten older, it has changed, for different things. But, the school system had their own behavioral program, and I put my program to the school for my son, and it really, I think, changed that from don't do to this is what will you get if you do, right? Or there's consequences.
You're creating a positivity rather than the negativity.
Yes, yes, and I think that's important. Each child is different.
Yes, thank you very much. That's an important coping strategy, is to try and make every situation as positive as possible. And now I'm turning particularly to, thank you. Another audience member would like to offer some insights.
We try to make always a positive situation for humanity, and what help some more is visualization. Visualization, we make a little pictogram with this, when you stand up.
Yes.
And teach on.
Get ready.
Get ready. We have a little picture with the plant. Nice pictures on the vacuum board with the Russian keys, and we start with good things.
Yes.
That's great advice. Sometimes it's easier to use pictures than words, and pictures speak for themselves without having to say no, don't do, or do. It's not an instruction. It's a picture that will help the child and help the parents. And now I come to a subject that I hope some of our parents with children over the age of 12 or 13 may be willing to answer. And it's a question that maybe nobody wants to answer. How do you cope with puberty? There's a lot of laughter, but I don't think anybody wants to answer the question. Yeah, Debbie, she's game for it. Good show.
Yeah, well, Gavin also had pre-puberty, so Remy went into puberty early, and they had to give him something to keep his puberty away. But and how we knew was he was very interested in girls at a very early age and pictures of girls, which is interesting. They can find very easy anywhere.
Yeah.
But we have always discussed with him why these behaviors are not appropriate, and as well, never talked with the doctors about him, but always with him. That his diagnosis prior to being diagnosed with AOG2 didn't define him.
Right.
It was just a part of him. So he had to make the decision to go past it. So once they took the puberty things out, we're dealing with a lot of that now at 20, where online predators are terrible. So,
Yes.
and at an age where it's hard to, keep things away. He also has a job, and at the job they find ways to push buttons.
Thank you very much. I know it's a difficult question, but as I said, we're here together to share and learn, to care and empower each other.
I don't know the baby name, but
Debbie?
it's the same thing I have with my son also. Started young with puberty, also pictures, videos, he didn't make nothing special with it. Well, we talked a lot about it and keep on talking with him about it. And give him the space to find out for himself. that's what I did with him. My daughter is the next question, that other question, she started puberty late, so she's now really being with puberty. And we went to the doctor and he said, oh, she's late. So most of the problems we have now is with her. And, but she's not interested in boys, so yeah. But it's sometimes difficult to tell her, this is, wait, this is not good, and yes, that's very difficult. Sometimes I don't know precisely what to do, and sometimes, and she's very, starting out skin. Yes, yes, yeah. Thank you very much.
Yes. Monica, do you have any questions from the chat? Oh, wow, we need to receive comments too.
Yeah, the mother of her 12-year-old daughter said that she doesn't see any difficulties because she wrote, I respect, I don't discipline. It's also discipline. Holly likes to walk in low bubbles, so I will offer that. She isn't difficult. I think it fits to the point we had before, the saying no. I can also add something from a 16-year-old perspective. I can say that it was really, really a tough time with a girl in puberty who can't speak. Because there was a lot of bad news, I would say, and it was really hard to find out what was the reason. We have a daughter who's 14, and I know it's really difficult to find a reason anyway. But nevertheless, there's a kind of stuff in communication in this period you have to overcome. So I'm really happy that this time seems to be over, but it was really a tough time, I have to say.
Yes.
Yeah.
Thank you very much. I'm conscious of time and lunch. And we were going to add on a little bit more about the power of telling your story when you need to tell your story. And I think we can do that informally later during the other sessions or during the lunch and tea breaks, because this is something that I'm passionate about. A lot of parents who have a need for their children, a rare disease or other, don't necessarily know how to ask for it. And you have to take the approach of almost like telling a story. Once upon a time in a faraway land, you wouldn't start it that way, but you would start doing something that's chronological, explain who you are, but always go to that appointment knowing what you want to get out of it, and stipulate that not only in your head, but stipulate that to the people you're speaking to. Now, one gentleman that I saw, he was so angry. He was dealing with problems for his son who has a very rare disease. And rather than be calm, collected, and succinct, he was shouting. Now, as you know, if somebody shouts at you, you aren't going to listen. Similarly, if you come across as not structured and wishy-washy and you start sentences and you don't finish them, you will confuse the person you're talking to and you won't get what you want. And we can discuss that over lunch and coffee, because this is something that I'd like to support people in going forward. If you have a story to tell and you would like us to publish it, I will help you. I will take the notes and I will write it up in the way that we can get these stories published. And I really want to get all your stories published because it's going to help us further down the line. We need references, we need citations to refer to. So by writing for journals, and not writing for the newspaper, writing for medical journals, and because of the nature of the disease, I would obviously recommend a journal for rare diseases. You then start raising the profile, you raise awareness, and by that we can join the dots. So my final thing is to say thank you very much to all of you for being here in the room and online. And if you can, please put your hands together to say a very big thank you to our panelists. Whoa. And an extra special thank you to Nora for making this possible. Because as you know, as a parent, where she has found the time in her work and caring for Paula and being a partner and being a daughter and a friend, it's a miracle. But she's opened a pathway to something that is going to make a difference, because collectively we can do far more than you can each do individually. And my role in all of this is to help you. So last night I had a discussion with somebody who I didn't know. A friend of mine lives in Munich. I mentioned I was coming to Regensburg, and he said, oh, that's funny. My very first boss is a serial entrepreneur and he lives in Regensburg. And I said, give me his name and number. And we met up last night. And the result is that now we have, I don't know if it will be a funder, but we have an angel, because I told him a story. I told him about all of you and your children. And the result is that he is going to connect us with the people that we need. We really do need as much publicity as possible. As I was saying earlier to a group of people, just publishing something in a journal, not the writing because I'm doing that voluntarily, but the publication can cost anything between 2,000 and 3,000 euros. People are willing to fund things to be published which are going to help children and parents alike. And my plea is to all of you to share your stories, to let's get it out there together. And of course, a big thank you to Nora.